Morning, Susan. I'm just checking my audio and video.
All good.
Morning, Pat. How are you?
I'm well, thank you. Can you hear me okay?
I can. Is the secretary joining and is she here?
Sure, if she's joining. So you should feel free if she isn't able to be here to just hand it off to me.
Okay.
Thank you. I mean, I think she was planning to, but who knows how her day is going.
Sure. Okay. Why don't I give it one extra minute or so just to buy a little time? I'll give it 2 minutes and I'll call the order meeting in a couple minutes.
Great, thank you.
Hey, Mr. Chair, Mike Fisher here.
Hey, good morning, Mike.
Good morning. Hey, I don't know if today is a good day to do it or if there's possibly time, but I wouldn't mind having a few minutes at the very end of the meeting to give a non-ahead comment or update, open enrollment and those kinds of things.
Yeah, no problem at all. Why don't we do the ahead presentation? I'll take public comment and then I'll turn to you after that. I think that's a good point.
Sounds good.
Thanks. Okay, I'll call to order the Green Mountain Care Board's hearing of December 9th, 2024. We have one substantive presentation today, which is an ahead model update, which will be presented by AHS and Michelle Degree. Before we turn to that, we have minutes from December 4th, which I move to approve.
Second.
All in favor of approval, say aye.
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 Aye. And the minutes are approved. We do not have an executive director's report today, so I'll turn it over to Michelle Degree, our health policy project director, and Miss Pat Jones, the project and operations director from DVHA.
Thank you, Chair Foster. Pat, I'm going to get my slides up. I believe you're going to kick us off, so let me share my screen. Cool. Can you confirm you're able to see that?
Yes, thank you.
Yes.
Thank you. And just let me know when you'd like me to advance.
You can go ahead and advance. Let's dive right in, and thank you, Chair Foster and Michelle, for kicking us off. So today we want to give an update on the AHEAD model, and it's a very substantive update. We have posted what is called the term sheet on the AHS and GMCB websites. And so we will be spending time today really delving into what the term sheet is and what is in that term sheet. But I'd like to start just by providing some background. I want to especially start with acknowledgements because, as folks can imagine, there's been quite a bit of work and engagement with the Centers for Medicare and Medicaid Services, also known as CMS, on the AHEAD model. And so I want to take a minute to really recognize the work of the negotiating team and staff members who have been supporting that team. So from the Green Mountain Care Board, Board Member Robin Lunge and Board Member David Merman have been delegated the responsibility for serving on the negotiating team. So many thanks to them, and also Michelle Degree, who has provided many hours of staff time and expertise in the negotiating process. And then from AHS, our secretary, Jenny Samuelson, is on the negotiating team. Our healthcare reform director, Brendan Krause, who couldn't be here today, so I'm pinch hitting here for him. Administrative Services Director, Fran Hodgins, our Health Services Researcher, Jeff Batista, and then most recently, our new Deputy Healthcare Reform Director, Sarah Rosenblum. So many thanks to all those people and others as well. It's been quite a team effort as we have worked through this process. So next slide. So a little bit of background and context here. So I think most people know that really before we even applied for the AHEAD model back in March, we were working together with multiple stakeholders through the healthcare reform work group and a number of subgroups on issues that are really facing Vermont's healthcare system. So beginning in the summer of 2022, there was a short-term provider stability subgroup that was established, and that group really developed about 22 recommendations related to workforce, system flow, revenue, and regulation. And the goal there was really to improve short-term provider stability, and a number of initiatives came out of that work. And then in the fall of that year, we really started looking at different models, partly in response to Act 167 from the legislature, but really started looking at a framework for discussions on a future multi-payer model. So that work was ongoing. And then in February of 23, there were two technical subgroups that were established. One was to look at how we might design a Vermont-specific hospital global budget methodology. Hospital global budgets are one of the components of the AHEAD model, and so we did some really deep work on that, and Robin Lunge actually chaired that group. And then we also had a subgroup that looked at Medicare waivers. What were some of the waivers of payment regulations that could for Medicare that could actually improve care delivery? And so that subgroup came up with a number of recommendations as well. And all the while, we were engaging in regular discussions with CMS so that we could learn more about the AHEAD model and, in fact, provide some input on the model. Next slide. So in July of 2024, Vermont got notice that we had been accepted into the AHEAD model on the basis of our March application. And so at that point, the agency and the Green Mountain Care Board began jointly negotiating with CMS on the terms of a potential state agreement for the AHEAD model. Vermont was accepted into cohort 1, meaning that we could begin as soon as January of 2026. One other state was accepted into cohort 1, and that was Maryland. Maryland has signed its state agreement. It was signed on November 1st, and it's publicly available. You can see the link there. Since then, Other states have been accepted into cohort 2, Connecticut and Hawaii in particular. And then more recently, Rhode Island and a portion of New York were accepted into cohort 3. Both of those cohorts would have a start date of January 2027. So I just want to be really clear here. While we've been accepted into cohort 1 of the AHEAD model, we certainly are negotiating both key terms and then ultimately a state agreement. Vermont has not yet signed a state agreement with CMS, so therefore we are not yet committed to participating in the AHEAD model. When that agreement is signed, if and when, that is the point at which we're officially committed to participating in the model. Next slide. So folks have seen this slide before. It is actually a CMS slide. Some people think it's too busy. I find it very helpful for sort of level setting what the AHEAD model is. So AHEAD stands for States Advancing All-Payer Health Equity Approaches and Development. The idea is to improve health outcomes across multiple states. CMS has said that they're not going to do models that only one state can participate in anymore. So they, definitely were looking for up to 8 states. And as I noted before, they've got 6 that they've approved at this point. But a key element of this model is the statewide accountability targets. And they fall into 3 buckets. The first is that CMS has the goal of mitigating or reducing growth in total cost of care. And so when you think of total cost of care, think of all your sort of hospital, community-based healthcare providers, professional services. So a lot of those services that are provided in offices, clinician offices, or in hospitals are include, home health is in there as well, are considered in total cost of care. And so the idea is to reduce growth in total cost of care for both Medicare and across all payers in the states that participate in the AHEAD model. And the states will be accountable for that. The second is primary care investment. And that's a sort of a new approach from CMS in its models. People have been talking about increasing primary care investment for quite some time. But the idea here is to increase that investment both in Medicare and across all payers as well. And then the third bucket relates to equity and population health outcomes. So reducing disparities in health, quality measures, those types of outcomes. So that's what the state would be accountable for under the AHEAD model. And then the components to help support that include hospital global budgets, which I mentioned already, a different way of paying for hospital care that's really based on historical revenue with some adjustments. So a set sum of money for hospital inpatient and outpatient services. Primary care ahead, which includes some enhanced payments for primary care practices, and also some focus on care transformation. And then cooperative agreement funding from the federal government to help support states in starting up this model. And the cooperative agreement funding for the cohort 1 states is about $12 million over the first 5.5 years of the model. $12 million total, not per year. And then you can see in the lower row that what CMS thinks are the strategies that can help support this work include ensuring that equity and reducing disparities in health is integrated across the model, that there's integration of mental health and substance use disorder treatment. Behavioral health is a term that CMS uses. We do not use that term here. An all or multi-payer approach, so involvement of Medicare, Medicaid, and commercial insurers in this model. Alignment with work that's already happening in states around Medicaid, and we see in our state, we see that particularly in the primary care space. And then supporting acceleration of existing state innovations. So that's sort of the, AHEAD model at a glance. I like to start with that because it just so folks can remember what is it that we're trying to accomplish here. Next slide. So what I'd like to do now is really dig into the term sheet. There are 20 discrete terms that we have negotiated with CMS. But Michelle, if you go to the next slide, I want to just talk about what is the term sheet. So really think of it as a statement of key points that at this juncture in our negotiations, Vermont and CMS have agreed on. They are not final terms, and I think it's fair to say that there are, likely to be some changes in the terms as we continue to negotiate. Anything that is in the term sheet, it's subject to modification. It would need to be ratified in a subsequent state agreement if it were to become final. And that state agreement will require signatures and approval from HS, from the governor, and from the Green Mountain Care Board. It's not a form, the term sheet, again, I'm sort of repeating myself, but non-binding. It's not a formal action of the Green Mountain Care Board or any other state entity. So, one thing we've tried to emphasize is that whether, Vermont is able to participate in the AHEAD model or not really is contingent on the legislature and the executive branch appropriating sufficient resources so that the GMCB can independently regulate in a way that aligns with the state agreement and the model, and the state can implement the model. So at the risk of repeating myself, prior to signing this agreement, and that's all three signatories, Vermont is not committed to participating in the AHEAD model. And you'll see the links there for our respective websites where this term sheet can be found. Next slide. And the next one, what I'm going to do, so we've sort of split it into two parts. As I mentioned, there are 20 terms in the term sheet. And so the first several, I think 10 or 12, are really, I think, what we consider the highlights in the term sheet. And then the remaining terms, which we also have slides for and are in the term sheet, they tend to be more weedy or more in the details, but really trying here to outline what those highlights are in the term sheet. The term sheet is positively loaded with acronyms. So what we've tried to do here is clarify where you see an acronym, what it stands for, to make it easier to understand the language here. So the first, key area that I want to highlight is the Medicare fee-for-service total cost of care target. So as I had mentioned on the CMS slide, the state will be accountable for moderating growth in total cost of care for both Medicare and for all payers. And so this speaks directly obviously in agreement with Medicare. They're most interested in the Medicare targets, but they're also very keenly interested in the all-payer targets as well. So this particular term speaks to the Medicare fee-for-service total cost of care target. And when we say fee-for-service, we're talking about the Medicare beneficiaries who get regular, traditional type Medicare, not folks who are in Medicare Advantage plans. So this term speaks to how we would set the historic benchmark for that total cost of care. So it's that starting point that we then work from and have to see reduced growth. So we are, and the CMS allowed states to consider up to 3 baseline years. We have decided that it would be best for Vermont to use the 2023 baseline year and weight that at 100%. So that will be the basis. The baseline expenditure, in addition, will include not what we call non-claims based payments. So, CMS will look at what the claims are showing, but also we want to include savings that we've seen from the Vermont all-payer model and other models, and then advanced shared savings payments that we've received under the current model. That includes payments for the blueprint, both for primary care practices and community health teams, and for the support and services at home program. So there's additional funding that goes into that baseline for Vermont. The baseline will then be trended forward, for inflation and other factors from year to year. So it doesn't just start at one level and stay there. That last sentence is a bit of a detail, but there was some urinary catheter fraud, not in Vermont, but nationally, and some Vermonters received care from some of those providers. And so they are not counting those payments in the baseline. It's not a ton of money, but it is something that CMS wanted to make sure was in the term. So just to give people a sense of what the 2023 per beneficiary, so per Medicare fee-for-service beneficiary per year would be, it is, the calculation has been $12,040 per beneficiary per year. So that's the total cost of care target. Next slide. For primary care, I had mentioned earlier that the CMS has said that they will make additional payments to primary care practices that agree to participate in the AHEAD model. They call it an enhanced primary care payment, another acronym, EPCP. The average, and this will be for participating practices and for the Medicare fee-for-service beneficiaries that are attributed to those participating practices. So CMS has said that they will provide an average of $17 per beneficiary per month to participating practices. There's some adjustments that can be made around like risk adjustment and quality results and that type of thing. But in no case would that amount go below $15 per beneficiary per month, and it would not go above $21 per beneficiary per month. So the range is 15 to 21 with an average of 17. And that's for the first performance year. The EPCP will then be adjusted for inflation each year beginning in performance year 2. So that's one way that Medicare is agreeing to increase investment in primary care. Next slide. So a little more about primary care ahead. One of the objectives of CMS is for primary care practices to use that funding to transform care. And they outline 3 different areas that they're focused on. One is integration of mental health and substance use disorder care into primary care. Another is screening for and addressing health-related social needs for the people who receive care at the practice. And then a third is coordination of care, and they really focus there on coordination between primary and specialty care. Vermont's Blueprint for Health program really is sort of ahead of the curve on those areas. And so it was really important to us as we were working with CMS on this model that that additional requirements not be layered on top of what practices already agree to do as part of the Blueprint for Health. And by far the bulk of our primary care practices participate in the Blueprint. It's a multi-payer model, so it's supported by commercial insurers as well as Medicare through our current all-payer model, and then Medicaid as well. It includes resources for integrating mental health and substance use disorder treatment. There are community health teams that help coordinate care. Screening for health-related social needs is all a part of the Blueprint for Health. And so it was really important to us. We've heard from primary care about administrative burden. It was really important for us not to have this be additional burden. And so there's a statement in the term sheet that actually says that the Blueprint is expected to meet the care transformation requirements in primary care ahead. And further, CMS has said that they, if they want reporting from practices, they will repurpose what the practices and health service areas already report to the state under the Blueprint for the purposes of primary care ahead reporting. So that was really important to us, and those statements are in the term sheet. They want to make sure that specialty care, that coordination with specialty care continues to evolve. And so you'll see that last sentence there that says by the 4th performance year, the state will make sure that the Blueprint's care transformation requirements are evolving. And part of that is to align, this will come up later, but one nuance in Vermont's agreement is that there is an expectation that we have what we call investment and access targets. So we've heard a lot about concerns with access to care. And so CMS just wants to make sure that what happens in the Blueprint care transformation aligns with what is happening with targets for access and investment. And I'll get into that in a little more detail in a couple of slides. So that's care transformation requirements. Bottom line, very, very much aligned with the what's happening in the Blueprint for Health. Thanks, Michelle. Next slide. And then finally, relating to primary care, I had mentioned in the CMS slide that there is a primary care investment target, which is something new to us. Our current model doesn't have that. And again, there's a Medicare fee-for-service goal to increase investment in primary care. And then the expectation is that the state will set an all-payer primary care investment target too. And so CMS has a particular way of measuring their primary care investment. And so by their measure, our current calculation is that 4.47% of Vermont's total cost of care expenditures are devoted to primary care. And so the goal would be that by the end of performance year 9, that would be increased on the Medicare side to 5.17%. And there will be interim targets established along the way. And again, there will be a separate target for all-payer primary care investment as well. So that's a notable accountability in this model. Next slide. So one other thing about the primary care investment target is that we just wanted to be sure that blueprint funding and SASH, really, so blueprint and SASH, it's around $10 million this year. That is, so CMS is currently giving us that funding to cover Medicare's share of the blueprint. And really, SASH is almost totally funded by Medicare because it's a program for Medicare beneficiaries. So we wanted to make sure, and they did as well, that funding, which will continue under an AHEAD model, we would continue to receive that blueprint and SASH funding from CMS, that would be included in primary care spending when they calculate that Medicare fee-for-service primary care investment target, and when they calculate performance on the all-payer primary care investment target as well. So just, codifying that would be included in that calculation. Next slide, because that's unique to Vermont. Other states don't have that blueprint and SASH funding. Okay, so that, I think that covers much of the primary care part of the term sheet. What I'd like to turn to next is the hospital global budget calculations. And so states in the AHEAD model have two options. They can either go with a hospital global budget methodology that CMS designs, and they're on, I think, version 2 and are about to release version 3 of their hospital global budget methodology, or states can design their own hospital global budget methodology that would be applied under the AHEAD model. And I had mentioned earlier in one of my first slides that we did have a subgroup that met, oh gosh, Robin probably knows by heart, but I would say 16 times, maybe, 2-hour meetings, very detailed meetings to outline what a state hospital global budget methodology might look like if we were to go with our own design, or if we were to augment CMS's design, therefore making it our own. So one of the elements that we think is important, and that CMS does too, is that there be an incentive in the hospital global budgets to support hospitals in early participation, because there will be definitely some investment that would be needed in care management, care transformation operations, and so forth. So CMS has 1% incentive in their model. We actually felt like that it was a good idea, and that we wanted to help a little bit with that. So we have asked to establish what we're calling a hospital global budget operations incentive, so HGBOI. And what we have looked at in the term sheet is an upward adjustment of no less than 2% for a hospital and up to 3%. We have some very small hospitals, so we felt like that range of 2 to 3% made sense. So for hospitals that are your prospective payment system hospitals, your larger hospitals, CMS is saying that this transformation incentive will be available for the first 3 performance years. So those hospitals would get no more than 3 years. Our larger hospitals, the way that we've constructed it, they joined in performance year 1, they'd get 3 years of incentive. If they joined in 2, they'd only get 2. If they joined in 3, they'd only get 1 year. And so that's the way we would construct it for those larger hospitals. For critical access hospitals, who, we really want to make sure, should they join the model, that they're adequately supported. CMS has agreed that if critical access hospitals join at any point before performance year 5, they would be eligible for that incentive for the first 3 years that they participate. So it actually adds some additional length of time and support in critical access hospitals making that decision on participation. Next slide. So another really important opportunity in the AHEAD model for Vermont is what we are calling an Equity, Access, and Transformation Fund. And so the objective here is that we know that there are challenges in Vermont in terms of affordability, in terms of equity, in terms of access to care, and that goes across the care continuum. It's beyond, hospital care. And so CMS has agreed that Vermont can and will establish what we are calling an Equity, Access, and Statewide Transformation Fund, or the EAST Fund, for Vermont health and community service providers. It can be funded by hospital revenue that comes in through that hospital global budget. It would be directed by the Green Mountain Care Board under, the hospital budget setting authority that the board has, and also the CMS would look to us to describe the process in the Vermont designed hospital global budget methodology. And so it's a real opportunity, and it could in fact be substantial funding that would allow us to really invest in healthcare and community-based care in Vermont across that care continuum. There's some requirements. The first is that we would need to meet those total cost of care savings targets that we've mentioned as an accountability. And there would also have to be a certain amount of hospital participation that we would see in the model as well, and we'll get to that in a minute. These terms are out of order from what they are in the term sheet for flow purposes, so just keep that in mind as you look at the slides. Folks who look at the term sheet will see the actual order of that. And then the state will be required to establish some, we have our statewide accountability targets. So any activities that are supported by the fund need to support those. They need to support the goals of the AHEAD model. They need to be consistent with Vermont law. And you'll see that the state will be accountable for not only the population health and equity targets that I talked about in the CMS slide, but we're also going to be required, starting in performance year 4, to establish investment and access targets as well. And so that'll be a key focus for this East Fund allocation. So next slide. So this is where we talk about those investment and access targets. So again, by performance year 4, CMS wants to see Vermont include some specific Medicare fee-for-service investment and access targets. And together we have outlined, in particular, providers such as home health, skilled nursing, mental health, folks who serve people with substance use disorder, and selected specialty care as well. So the idea here is that there will be targets for investment and access related to those sectors. We will submit those targets in what is being called a state transformation plan. It'll be subject to CMS approval. We can update the investment and access targets as time goes on. But they are considered, this is key, part of the statewide accountability targets. And so we will be expected to meet those targets. So it puts some structure around the use of those funds. Next slide. This speaks to what the expectations are from CMS in terms of savings or reducing growth and total cost of care. So Vermont and other states that are participating in this model will need to show savings for the model. In the initial year, it's gross savings, so it's not net of investments that CMS makes in Vermont. They'll be looking more to net savings starting in the 4th performance year. The average savings over the life of the model would be that it would be 0.53% below national trend. And that annually, that would translate into a savings of 0.1% below the trend. That would be a constant. The way that we've written it into the term sheet is that it would be a constant 0.1% for each year of the model. This next number, I just want to be really clear, it's an estimate. It's illustrative only. But based on current assumptions, the estimate from CMS is that the savings would be just under 80 million, so about 79.7 million over 9 performance years, so across the entire length of the model. But again, these are illustrative. They're based on assumptions. These numbers won't be included in the state agreement or in the accountability targets, but it gives you a sense of the amount of savings that they would anticipate seeing in this model. Next slide. Payer participation. Here, the AHEAD model in general requires that there be hospital global budgets for commercial payers, and that at least one commercial payer, and that could be a health plan, a self-insured plan, it could be an entire book of business, could be, for that matter, I suppose, a Medicare Advantage plan, which are considered commercial payers, but at least one payer would have to participate by performance year 2 and in each subsequent year of the model. That's the requirement for all states in the AHEAD model. CMS is, and we as well, are obviously interested in seeing as much commercial participation as we can in this model. And so the term sheet states that the state will assess options to effectuate ERISA compliant. ERISA is the Employment Retirement Income Security Act, federal law. Mandatory participation for implementation by performance year 3, and will notify CMS of its selected options by the end of performance year 1. So there's, there's quite a bit of, work to do on what the state could have as options. And so that's an analysis that CMS would like to see and is in the term sheet. Next slide. In terms of hospital participation, and I had alluded to this earlier when I was talking about the East Fund, but in order to get, in order to have access to those funds, we have to meet those total cost of care savings targets that I mentioned a couple of slides ago. But in addition, we have to meet hospital participation requirements. And so what is laid out in the term sheet is that by, performance year 1, and this is standard for the AHEAD model, at least 10% of Vermont's Medicare fee-for-service net patient revenue for inpatient and outpatient hospital services is under a hospital global budget. So 10% in performance year 1. But then, the Vermont terms get a bit more ambitious. So we would then be looking for 50% of that Medicare fee-for-service net patient revenue under a hospital global budget in performance year 2. So let me just say, performance year 1, 2 or 3 single hospitals could probably meet that 10% requirement. The 50%, you're looking at least 2 hospitals. And then from there, we'd be looking at 80% of Medicare fee-for-service net patient revenue under hospital global budgets in performance years 3 and 4. And that's probably pretty much all of your PPS, those larger hospitals. And then 85% in performance year 5 and beyond. And that probably brings at least 1 critical access hospital into the mix. So those are the hospital participation requirements that are laid out in the term sheet. And again, they're important for their milestones that the state would be accountable for, and they would also help with the East Fund as well. Next slide. This is sort of the final slide that I have in the, highlights. And so I'll stop after this and see if the board chair would like me to continue to talk about the other elements of the term sheet. There's probably 8 or 9 more that are those more detailed elements. But I know that Michelle Degree also is planning to present information on timeline and on sort of a summary of the public comment that's been received to date. So I'll, Chair Foster, I'll let you decide how you want to break this up. But a final term that I want to highlight is that there is enforcement action and potential termination in the state agreement. And so in the term sheet, what we have highlighted is that the state can terminate this agreement at any time during the pre-implementation period. And we are in the pre-implementation period now. The pre-implementation period is basically until, from time of acceptance in the model until the time at which the model goes into implementation. So for cohort 1 states, that's January 1st of 2026. Cohort 2 and 3, it's January of 2027. So this says that the state can terminate the agreement at any time during that pre-implementation with 30 days advance notice to CMS. And I just remembered that I added another slide, I think, to this section. So I'll have one more before we serve at our potential stopping point. Oh, I thought, yeah, that was it, cohort selection. Yep. So, the state is looking at, there's benefits to participating in cohort 1, there's challenges. And so the state is really evaluating the model for participation in cohort 1. It's possible that we could elect to move to cohort 2. That's not without its own set of challenges. But what this says is that prior to executing the state agreement or April 1st of 25, whichever comes first, we have to make a decision on cohort 1, cohort 2. So just wanted to highlight that as well. So that is somewhat of a natural stopping point here. As I said, there are some more detailed terms that I'm happy to go through before turning it over to Michelle, but would just like to check in and see what the wishes of the chair
are. Thank you very much. I think it makes sense to keep going. I think some of these will be relevant to, I don't want board members asking questions that will be answered in this. And I think I saw a couple that could be. So let's keep going. Thank you.
Okay, sounds great. All right, so next slide. So this is, and if anyone has any questions on this, I will probably beg the chair to let Dr. Merman answer this, because he probably has as deep an understanding of this as any of us. But there are two trend factors that CMS propose using in the HEAD model. One is called the United States per capita costs, or the USPCC, and the other is called the Accountable Care Perspective Trend, the ACPT. We had quite a bit of discussion on whether we wanted to use just the USPCC, it's one that's a little more familiar to folks, or whether we wanted, CMS was asking for requiring a weighted average of the two. And after a lot of discussion and deliberation, we felt that it made more sense to use the weighted average that CMS is recommending of those two trend factors. Next slide. I mentioned this earlier, but for the Medicare fee-for-service total cost of care target, the savings component, we could have, had less savings or even no savings earlier, but then have more later. We decided that it was most beneficial for Vermont to have a constant savings target, so savings off trend. So that calculated out to be 0.1% for every year of the model. Next slide. Out-of-state spending. So again, this is really relevant to that Medicare fee-for-service total cost of care target. We'll have a target that we have to live within. And CMS noted that, Vermont has some a fairly high total out-of-state spending. So it's greater than 30% of our total cost of care is healthcare dollars that are being spent out of state. And so CMS agreed that if our, we calculate our total cost of care performance, we exceed the target. They did say that if the cause of that exceeding the target is the out-of-state spending, and their bar is that you can't exceed the target for any 2 performance years within a period of 3 consecutive performance years. They agreed that if that's the cause of exceeding the target, that they would not issue a warning notice or take enforcement action. So recognition from them that, we have fairly high out-of-state spending, which, those providers won't be under hospital global budgets, for example, if they're hospital providers. Next slide. Advanced alternative payment model status. This will, resonate for folks, particularly in primary care and specialists as well. Under our current model, the Vermont the all-payer model is considered to be what CMS calls an advanced alternative payment model. And what that means is that practices don't have to, there's a quality program that CMS has established called MIPS, or the Merit-Based Incentive Payment System. And under the current model, practices don't have to collect and report data in order to get a quality bump, a bit of a bonus for quality performance, because the model builds in quality performance and payment for that performance. So we are very interested, and certainly the clinicians and practices in Vermont are very interested in seeing if this model, they've said generally that AHEAD primary care doesn't quite hit the advanced alternative payment model bar, but because we have the Blueprint for Health and other initiatives, we're working with CMS to see if the way that we construct our hospital global budget methodology, the care transformation work with the Blueprint and so forth, if that can meet the criteria for advanced alternative payment model status, which would again afford that exemption from having to report and would confer the additional payments to those practices. So it's something we've both CMS and Vermont have been working hard on. It's a continuing discussion, but they have committed to evaluate that, which is a good sign. Next slide. The hospital global budget operations incentive, that's that 2 to 3% with the slightly variable application to prospective payment system hospitals and critical access hospitals. Just clarification that that incentive is only available to hospitals that participate in the model. And furthermore, and this is consistent with the AHEAD model generally, hospitals that exit the model prior to performance year 6 would have to repay any of those payments to CMS. Next slide. Corrective action. This just notes that I had talked about the hospital participation requirements, and that 80% of net patient revenue, Medicare fee-for-service net patient revenue, would have to be in a global budget in performance year 3. and 85% by 3 and 4, and 85% performance year 5 and later. This just notes that if we don't hit those targets, CMS will issue a warning notice and may pursue corrective action. Next slide. Blueprint. This says that in Vermont's state-designed hospital global budget methodology, that the state will describe how Blueprint funds, and that includes Blueprint and SASH. Again, this year it's about $10 million. How it'll be directed to one or more of the hospitals that are participating in hospital global budgets, but then will be directed to Blueprint and SASH, and the state will hold the hospital accountable for making sure that's distributed. They need the payment mechanism through the hospitals, but this is just assuring CMS that we will in fact get that funding to Blueprint and SASH. Next slide. Okay, I think that's those are in a nutshell, and I hope with some level of clarity, the 20 terms that are in that non-binding term sheet. And so that's the end of what I had to present. Thank you.
Thank you, Pat. So just pretty quickly, I'm just going to review the board process and the timeline for the next little bit. A reminder that we have an ongoing public comment period. It has been open since midway through 2023. And I'll talk about some themes on the next slide. So here we are today, December 9th. We're having an overview of the term sheet. Starting today through the end of the month, our team is going to continue to work with CMMI to work on our state agreement. And any changes or updates to the term sheet, as Pat said, that's still very possible. And then ongoing review and consideration of any additional public comments we received during that time period. The goal right now is for the first week of January for the negotiating team to finalize that state agreement. January 8th, we have a board vote noticed and a presentation on the final state agreement. And then January 15th, we have an additional board vote notice with the goal of having all parties sign the state agreement by Friday, January 17th. I know that that is a pretty fast and accelerated timeline, but just wanted to lay that out here. Quickly, just talking about public comment. So again, we've had this open since 2023. That's a direct link to the public comments that we've received on our website. We've received 23 written public comments to date. Obviously, there have been public comments made in board presentations. I just wanted to highlight a couple of overarching themes. One of the main ones is funding for primary care. There have been a few comments related to access and affordability concerns, both in primary care and in the mental health and substance use disorder care space. A handful of, I'll call them analytic requests, but sort of more detailed analyses. So cost benefit analyses of participation. What are the true sort of fee for service counterfactuals here? So not participating, what would that look like? And some requests for analyses on reference-based pricing. Overarching theme of administrative burden. It goes back to what Pat was talking about with the AAPM status exemption, and then a handful of comments around voluntary and mandatory participation. And those are actually our additional slides for backup, just in case we need them. So with that, I will turn it back to you, Mr. Chair.
Thank you. I'll just open it to the board for questions and comments.
I don't have any questions, but happy to chime in as part of the discussion as we go along. I guess the couple of things I wanted to just highlight with a little more context is for anyone who's currently familiar with our existing state agreement, there is a withdrawal term after the agreement becomes effectuated, essentially currently of 180 days. We would expect to have that term also be included in the state agreement. I'm highlighting that because Pat highlighted the pre-implementation 30-day term, which is a special term that we wanted to ensure, given all the moving parts, that the state had an easier way to withdraw than the standard term. So I just wanted to put that in a little more context. And then the other component is in our current state agreement, the savings component is 0.2%. So this is less than the current savings component in our current agreement, although the TCOC is calculated differently under the new agreement. That methodology is included in the notice of funding opportunity, so is publicly available and has been since last year. So those are just a couple comments I wanted to make to add some context. Thanks.
Yeah, I have a couple comments and several comments and questions, actually. Thanks, Pat, for the presentation again and working together on this over what seems like quite a long period of time now. The first thing I kind of wanted to do, I definitely took a long time to wrap my head around the AHEAD model and the cadence of it. And so I just wanted to speak through the performance years kind of chronologically and talk about them in that way and see if that helps sort of communicate what happens as we go through this model. So performance year 1, which would be, if we were in cohort 1, would be 2026. If we were in cohort 2, it would be 2027. At this point, we're committing to 10%, if we sign the state agreement, 10% of hospital Medicare fee-for-service revenue being in the model. So it would be 10% of that hospital fee-for-service revenue to be in the model. That's 10% of the 100%, meaning all of the revenue in the state, not all of the revenue that's out of the state as well, because it's somewhere around 40% of our spending is out of state. So of the in-state hospital-based revenue, 10% would be in. So that could be one of 3 hospitals. It could be Rutland, CVMC, or UVM. In that first year, if we had a participating hospital, then my understanding is, and please anybody jump in or let me know if I'm misspeaking here, because I want to make sure I get this right, that all Blueprint associated practices, which would be that are not hospital associated, so FQHCs and independent practices, and if the hospital has primary care practices, they would be eligible for those $17, the ECPC, advanced primary care payments. So it's $17 per beneficiary per month for fee-for-service beneficiaries that are attributed to those practices. So that means that all the FQHCs are basically Blueprint associated. Most of the independent practices are Blueprint associated. So if they have Medicare fee-for-service beneficiaries, they get a $17 payment per month on average for those beneficiaries. And I can never quite remember how the average works out, but it's I think somewhat related to, Pat, maybe you could the complexity of the patient, the HCC scoring or something. I'm not. Yeah. Okay. All right. So then during that first year, 90% of the in-state revenue, roughly, it depends if UVM is in, they're clearly bigger, but if Rutland or CVMC, it'd end up be 85 to 88% of the in-state revenue for hospitals would just be in a regular plain old, still stay in the plain old fee-for-service rubric that we're in now, although without getting the prospective payments that are associated with the all-payer model. It's just, instead of being paid a fixed sum, it's regular fee-for-service for the rest of the 90% of the hospitals in that first year. So I guess the question that I had, and I think, Pat, you spoke with this, and I've struggled with where we landed on this, and I think I remember now, is that we don't have clear defined pathway that hospitals and providers are exempt from MIPS at this point in that first year. But if, and I don't think we even know that if we had 10% of hospitals in, I would assume that the 90% of hospitals that are not in, and 90% of revenues not in, would not be exempt from MIPS. But potentially the primary care practices could be exempt from MIPS. Is that fair to say? I guess, can you clarify the MIPS exemptions and who would be exempt and when, or do we know?
I can try. Chair Foster, do you want me to go ahead and address that question? Okay, I'm going to take that as a yes. Okay. So a couple things. One is you brought up a really important point, which is what primary care practices can participate in the model. So the way AHEAD is set up is that hospital-owned practices can participate only if their hospital is participating as in the hospital global budget part of the model, except, and this is relevant for Vermont, CMS did agree that rural health clinics, and we have a number of rural health clinics that are owned by hospitals. Rural health clinics can participate in primary care AHEAD regardless of whether their hospital is participating or not. And then in addition, as you said, federally qualified health centers can participate and independent practices can participate. The only requirement for those practices to participate is that they have to be participating in the state's Medicaid advanced primary care model. And in the case of Vermont, that's the Blueprint for Health. And virtually all practices, primary care practices in the state participate in the Blueprint. So, so little nuance there around the rural health clinics, they can participate regardless. But for other hospital-owned practices, their hospital would have to participate. In terms of MIPS, the MIPS exemption, it gets pretty the discussions we've been having have gotten pretty complicated pretty fast. But what CMS would be looking for, and we have, I sort of want to call out, we have a primary care work group that's included some clinicians as well as, leaders and the associations that represent them. And they've been incredibly helpful as part of this discussion. But what CMS is looking for is some kind of care relationship between a practice and a hospital. So it doesn't have to be that they're owned by the hospital. It doesn't, it may not even mean that their hospital and their health service areas participate if there's some kind of a care relationship with a hospital that is participating. And, so we've put forth a proposal to CMS to that point that, has we think a reasonable but broad, description of what a care relationship might look like. And, just because of, I think, bandwidth, they have it, they've looked at it, they know what we're striving for here, and we're just awaiting to hear what their thoughts are on that.
Okay, so it'd be related to the hospital's participation.
Yeah, but
Yep.
it doesn't
Okay.
necessarily have to be their hospital. That's the point I'm trying to make. Yeah, because how, better than anybody how things work. How people work from different health service areas. Sometimes the care is the care relationship is not necessarily between the provider and their home health service area hospital. So.
Great. All right. And then additionally, in performance year 1, all commercial revenue stays in its current form. Fee for service, revenue caps, price growth caps, however the guidance works out for that year, but no commercial payers in performance year 1. So
I think that practically speaking, that's true. I mean, nothing says they couldn't start participating sooner, but we'd have to develop a methodology and so forth. So yeah.
So in performance year 1, I think we could expect basically, a little under 90%, unless UVM was the hospital in, a little under 90% of the hospital-based Medicare fee-for-service revenue in the state to be in fee-for-service. Performance year 2, which would be calendar year, because Medicare is on calendar year, 27-28, we go up to 50%. So we're in 10% in year 1, 50% in year 2. Pat talked about this. That would mean basically every hospital but UVM, or UVM and a couple other hospitals could get to 50% revenue. And then we need to have one commercial payer in the second year. So 27 or 28, we'd have one commercial payer plan in, which, as Pat mentioned, could be, it seems pretty flexible from the standpoint that it could be, one self-insured plan could be in under a global budget. It's sort of a commercial pilot concept. But then in 28 and 29, performance year 3, 28 if we're cohort 1, 29 if we're cohort 2, we get 80% goes in under Medicare fee-for-service revenue, A and B, not professionals, A and B, in ahead. So basically, that would be every hospital but the critical access hospitals, or there could be some other combination if a bunch of critical access hospitals wanted to go in and a PPS hospital didn't want to or whatnot. But that's pretty much where we are in 3. And this would be a big year for the Green Mountain Care Board, because this would be the first year that the commercial budget, the global budget, would be implemented. So like in 2028, 2029, we're putting, 29, yes, 28, 29, we're putting in the first year of the broader commercial global budget methodology. And then in 29, 30, we're still at 80%. So we're kind of level in that amount, but I imagine, that developing and implementing a big, broad commercial global budget methodology will take some tweaks. I would think we would see tweaks going on probably yearly, as that occurs in Maryland. They're continuously trying to modify their methodology in order to, get the outcome everybody wants, or that's desired. Maybe not everybody. And then in 29-30, it looks like we also submit the state transformation plans, and the statewide investment and access targets are submitted and need to be approved in that time frame. And then you're in 30 or 31. Performance year 5 is when 1 or 2 critical access hospitals can come in if they aren't already in. Others can come in too. But I felt like I wanted to sort of talk through the sequence of that and just make sure that I think while it kind of only sits in one of the terms, or 2 of the terms, that's really combining the payers and the hospitals. To me, that's a huge part of our relationship with this model on the Green Mountain Care Board. All right, so Pat, there was a mention, I don't know if Secretary Samuelson's here, on Friday at HROC that there was a mention that there had been some modeling done of various contingencies within for ahead, and I was wondering if you're referring, as you know, I've done a bunch of work trying to come up with estimates for the Medicare TCOC and the fee-for-service counterfactual, but do you know if there's other modeling that's been done to evaluate the risks, the benefits, the contingencies regarding the ahead model, and if this could be shared with the board? Maybe I've seen some of it and didn't realize that it was that.
You mean quantitative modeling?
Yeah, I would think it would that's how what it seemed to refer to as modeling for contingencies to see if you know, how are the various ways this could play out with risks or
I
benefits.
mean, I know we've done some work around, you know, considerations, sort of risks, benefits. I mean, we've modeled what we think the funding could be that would be coming in. You know, we have some estimates of what we think primary care funding might look like. We have estimates of what the Blueprint and SASH funding might look like. We have, you know, estimates of what the maximum might be for that East fund. So, you know, I think there have been some, you know, and they're estimates, I want to be clear. Some are maybe grounded more in current model experience than others. But, you know, so we've done definitely, you know, done some work around that. I know your contractor had been doing some modeling work as well. So, you know, I think we're trying to get a sense of what this means for Vermont as much as we can, given that any calculation we do invariably includes some assumptions. If the chair is willing, I would, you know, I'm one person who's been part of a team effort. But if the chair is willing and others want to weigh in on that, I'd be grateful. So.
I have no problem if there's anyone else that has any thoughts or opinions on this issue. And I would just say it's something that I think we're all still thinking about and looking at as well. It's pretty dynamic negotiation and analysis. And so there probably are additional things we can all think about and look at.
Okay. One of the other things that I've been trying to understand, and Pat, maybe you know this, or Robin, or others on the call, is so in the term sheet, there's a term regarding being, I'm going to paraphrase it, held harmless for increases in out-of-state Medicare fee-for-service spending. So if the fee-for-service exceeds the total cost of, if out-of-state fee-for-service spending exceeds the total cost of care, we are not going to get a warning or enforcement action from CMS for going above the total cost of care. Do we know if do we have an understanding of how that would impact the East Fund funding? For instance, if the TCOC is exceeded, it sounds as if when I read that we won't get a warning or enforcement, but does that mean we can still access the money under the TCOC up to the TCOC minus that out-of-state spending? I'm trying to understand if there's another layer of protection there towards trying to draw down the savings, that fund, that money into the East Fund.
That's a really good question, and I don't think we have explicitly addressed that. If anyone knows differently, please chime in, because I haven't been in every single discussion, but it's a really, really good question, and it might be something we want to discuss.
I think we'll need to look at the draft state agreement language to see where it's included. If it's included in the enforcement section as a hold harmless from the warning notice, I would say it does not impact the ability to draw down the East Fund, because it would be like you've exceeded the TCOC 2 out of 3 years. But when we redo the math without out-of-state spending, we see that was the out-of-state spending was driving some of that. Therefore, we're not going to ding you. But I think there would have to be something explicit in the East Fund language to protect against that, because technically we would have exceeded the TCOC.
Okay.
But,
other thing
you
that
know, we really need
right.
to look at the language and the cross references and that kind of thing.
Yeah. The other thing that I was thinking about with out-of-state spending is, so if in a global budget we cap a hospital's revenue and we're being held harmless for out-of-state spending increases, well, one could see that a hospital may cut services to make their budget work, and then the patients could then seek those services out of state. So by capping our hospitals' revenue potential and uncapping out of state, we could just sort of just push that access out of state. So I was just trying to figure out, when rereading this over the last few days, I couldn't find any, but I don't know if anybody on the call can see incentives within this model as we've written it to avoid shifting care out of Vermont.
You know, I think we've talked a lot. There are a couple things I just want to highlight. One is that we've talked a lot in previous meetings about, you know, when we think about a framework or performance measurement framework for this model, you know, we've talked about, you know, the quality measures that CMS has outlined and, you know, other types of measures. But we've also talked about the need for a monitoring framework as well. And so I think it's going to be critical to look at measures that would address that. The other thing is that, as I had mentioned previously, the term sheet does include those investment and access targets, and that might be another area where we could really focus on our people getting access to important services here in Vermont.
And with those investment and access targets that we're defining for PY4, I mean, could we, do you think, is the way you read it, we could implement those before PY4?
I don't think there's anything that would preclude that in the in what I've seen in the term sheet or any draft of the agreement. Yep.
So one of the other questions I had rereading stuff was, we are agreeing to define an all-payer total cost of care growth target, and with approval by CMMI. But if we exceed our all-payer total cost of care growth target, we could have a warning or an enforcement from CMMI. And I was just trying to understand if anybody can conceive of what an enforcement from CMMI would be on Vermont if we exceeded our all-payer total cost of care growth target because of commercial or Medicaid spending.
I'll just chime in. I think the Medicaid spending's a little more complicated because they're separate. They're not called total cost of care, but the global commitment waiver will have budget neutrality provisions. So I think that's a more complicated answer that needs more, well, which I should not be giving because I'm way out of date on Medicaid. So I would say that I think with Medicaid, there's probably a complicated dance between CMMI and CMCS and the state Medicaid agency there. But typically our global commitment, quote unquote, cap has been quite generous. So that I think is not likely going to be a problem. On commercial, I think it would be difficult to see how they could enforce since they don't have commercial enforcement. So I think that in all likelihood, there would be a discussion where they would want to look at, is it Medicare that's driving the all-payer TCOC or commercial? So I think typically the experience with the warning letters has been, and again, you know, not necessarily the same people, so it could change, but it's been like looking for the state to rationalize and explain what's happening. So Maryland has an all-pair TCOC, so maybe one thing we could do is just go back to see if theirs has been exceeded and what happened and what the cause was. I don't know if it has or not, but that would be one analogy to look at.
That's good. I agree.
That's my speculation. Take it for what it is. That's my thinking out loud on that one.
All right, and then the rest of my thoughts here are more comments than questions, I think. So I do have some concerns I want to talk about, which is, I think one of the challenges of this model is that hospital facility revenue is in, but professional revenue, at least for Medicare, is out. We'd have to sort that out with commercial. So from a Medicare standpoint, to me, it seems rational that hospitals would be incentivized to do less or to at least spend less, but physicians, nurse practitioners, PAs, others who bill professionally could be incentivized to do more. So I'm concerned that in that current dynamic, we could create some significant conflict between what I refer to as providers, physicians, PAs, nurse practitioners, and other people who provide services, and the big P providers, hospitals and organizations that are the facilities that are billing in conflicting ways. There's conflicting incentives there. That's a concern I have. Another concern I have is regarding the methodology on service line changes, which I know that we're talking more about the term sheet today than the global budget methodology, but if a hospital wants to add or remove a service line in order to continue to get their allocated component of money or a proportional amount of money from that, they would need prospective approval by the Green Mountain Care Board and the CMI. And I think in all the sort of various targets and plans discussed in this agreement, I don't think that I still have a clear idea, and I don't think we've developed a clear idea of the criteria of the process of how we would determine service line adjustments. Let alone the timing for that. And so I just have concern and worry and that the process is going to be burdensome enough that it decreases flexibility. The process of GMCB and CMI having to approve or disapprove service line changes decreases the flexibility of hospitals to respond to, for a lot of small hospitals, the providers that are available to them to provide services. Another concern I have relates to a recent JAMA Health Forum article that was written by somebody from Johns Hopkins and University of Maryland regarding the Maryland model. And it's an article that lays out for academic medical centers some questions and concerns about global budgets and how to think about the AHEAD model. And three things that they cited in that article are three things that I think could be sequelae of this model if it's not more nuanced than I think we currently have it, which is a lot of incentives, I think, lead towards shrinking the hospital footprint, which is, for better or for worse, could lead to what it has in Maryland, substantial reductions in hospital bed availability, which they then attribute to increased ED boarding and long ED wait times. As an ED provider, I will tell you that that is a major safety issue and staffing issue and increases complexity of delivering care. So it is not reassuring to hear that a state that has done a lot of work in this area has reduced ED length of stay or ED wait times because of their improved access to primary care, but instead has increasing ED wait times because of their reduction in hospital beds and just the clogging up of the ED with boarding. So I think one of the other things that I struggle with in this model, which I think is a reflection on our last model, is the challenge of evaluating the model. When we look back at the all-payer model, at the beginning of the all-payer model, hospitals were in much better financial positions than they are now. Independent primary care practices, FQHCs, DAs, have never been soaring in Vermont, but I don't think the level of crisis that we're in now what was going on then. And we're a pretty fragile situation. The all-payer model started, COVID went in the middle. It's clouded the ability to evaluate the model. I think the viewpoint of health reform takes a long time to work, so we need to be patient. We need to wait to see these reforms work before we can evaluate them. And then the lag in availability of data, meaning that the evaluations tend to come quite a bit after the model year, makes it really challenging to evaluate the performance of this intervention in a real-time way. And I think that my big concern on that is that if we were to, it was discussed, I think, at HROC on Friday, the exit clauses. So if we decide we want to exit, we have easy ability to exit. But the problem is we don't know that it was the right thing to do until a year and a half later, when we can finally figure out what was occurring in that performance year. So I do think there's just inherent challenges with trying to understand real-time performance and real-time assessment to make decisions, to have actionable information that we can make decisions based upon our participation. And my last comment is, I think, maybe an insight into my personality, but I think a lot of people look at this model as bringing predictability and stability and flexibility to our healthcare system. And I look at this model and I worry about a lot of risk and trying to figure out if these risks can be mitigated. So I see financial risk of capping Medicare revenue at a growth rate that I'm concerned would not keep pace with our needs to improve access, and I think probably pent-up utilization demands. We have risks that with a change in federal administration, the interest and support for these experimental models could potentially wane. We just don't know. I think we have some risk to healthcare access. We've seen in Maryland dynamic changes in bed availability in hospitals and other access issues. We have risks to reducing services where there have been recruitment challenges. We have recruitment challenges throughout the state in various ways. I think we have seen this potentially in some of the recent closures where there was chronic recruitment challenges and reliance on contract labor, and contract labor is expensive. So when it's time to cut, you cut the things that are, contracted. And sometimes those are the things that we most need in our communities. I see risks of shifting care out of state. I see risks of shrinking hospitals in rural areas. The incentives to me look like it is potentially beneficial for a small hospital to shed services, keep revenue, but many of those communities don't have market viability to have independent specialty practices, other practices. And I still see risk of further increased reliance on commercial revenue. So, I think of risk a lot. I'm an emergency physician. I think we in my clinical job, I evaluate risk with limited information all day long. And certain risks I feel are worth the risk. If there's a situation where a failure to act is catastrophic, then sometimes it's worth the risk to see if you can mitigate that. There's other situations where the intervention may be more risky than the non-intervention. And so I'm trying to understand that balance within this model. I'm very interested now that this term sheet is public in hearing comments from Vermonters, from Vermont businesses, our health plans, plan administrators, our Blue Cross Blue Shield, MVP, primary care providers, and hospitals, is how they see how this plan could impact their healthcare or their ability to provide healthcare, or the sustainability of their organizations, or the sustainability of services in their community. And if there are significant risks there, and I'm very happy that we can now bring this public, so then we can learn from that and work on developing not just monitoring strategies, because I think the monitoring gives us the information far too late. It's the mitigation and the incentives and the prevention strategies of those risks that I'm most interested in. So I'm so sorry for taking up so much time today, and but I appreciate the opportunity to ask questions and give comments.
Thank you. Any other board members?
Sure. I'm happy. I've got some comments. I've got some questions. I guess I'm also cognizant of time. So, Chair Foster, what are you thinking about with time? In terms of, there's Board Member Walsh you still want to speak. We have public comment. I'm just trying to figure out timing here. I don't want to take up too much time.
I'm okay with going an extra half an hour till 12:30. If that's okay with Ms. Jones and Ms. Degree. Can you guys stay till 12:30?
I am able to do that.
I can as well. I do have a hard stop for 1 o'clock.
All right. Well, we can extend 30 minutes then. I think that would be okay.
Okay. I'll do the best I can, and maybe I'll hold some questions, because maybe there's some that are not that necessary. As I'm going through, I'll see what I can do to pare it back. But first, I certainly want to acknowledge and appreciate all the work that has been done to get us to this point. I know how many resources, energy, and time, and creative thinking and hard negotiating with CMS have been done. So I really do want to appreciate Secretary Samuelson, Pat, Robin, Dave, the staff at both, the board and AHS. I mean, I know it's really important work. I guess part of what I will say was I share many of the same concerns that Dave articulated. I'm not going to repeat them, but I am worried about the financial and implementation risks associated with the model. I'm concerned that the model will exacerbate rather than improve access. I'm not sure it improves affordability, and I worry that providers may not see this as a path to sustainability. So I am looking forward to the public comment from the providers to see how this term sheet sits with them. How do the hospitals feel? Is there going to be interest in joining this model from hospitals and from practices? And I ultimately do worry that we don't have the resources to implement this at the board at AHS. So those are just big bucket worries that I have. I know, Dave, you asked about some contingency modeling. I really think it's important. I saw the timeline for that vote in January. I really think it's critical that we kick the tires on that Delta TCOC, those projections, those federal investment dollars that we think we can access, because that's the big draw to this model, right? Is having these dollars that we otherwise would not have. But I need to understand, are those dollars really there? So this $138 million has been put out there as one estimate. I know it's just one estimate of additional federal dollars that may be coming into the state. I think we need to pressure test that. We need to understand whether 100% of those dollars will be accessed every year, even if minimal hospitals participate. I really just want to make sure. And if it's seems like that's the case, that should be in writing in the term sheet and in the state agreement. I think we need to project out that Delta TCOC using a wider range of trend assumptions, looking back at historical trend and sort of projecting that forward, also using the projections from the actuary. But I think we need a range of what those TCOC trend assumptions might look like. One of my biggest worries is projecting that Delta TCOC with different Medicare Advantage penetration assumptions. So those dollars available for federal investment, as I understand it, shrink as Medicare Advantage enrollment grows. And I think we're at about 30% MA now. The country as at large is about 54%. The Congressional Budget Office is projecting 64% national penetration by the end of the model. That was before the new administration moved in or is moving in. They really want to privatize Medicare. They want big infiltration of Medicare Advantage. So we really need to model out different scenarios of penetration at the state level, I think, to understand what that Delta TCOC is. I also think we need to model out what happens to that Delta TCOC with the current global budget methodology that relates to those service line closures. My vague recollection, and I could be wrong about this, and please do correct me, but is that hospitals retain 50% of the revenues that they earned from service lines, that if they close those service lines, they get to keep 50 to 80%, depending upon what type of hospital they are. But then those patients receive the care elsewhere. So those costs are to some degree counted multiple times then in that TCOC, right? They're keeping the revenue, and it's also care presumably is happening elsewhere. So understanding how that will impact the dollars available for the East Fund is really important. So I guess my point really here is I feel like I have so many unknowns still in terms of the factors that are going to impact how much money we get into the state that's above and beyond what we would otherwise anticipate. So that's one thing. And I think we need to weigh all those possible scenarios against the counterfactual of fee-for-service without a head. You know, we're seeing a recent claim surge in the state right now. If that continues, what does the Delta TCOC look like? And what would the revenue look like under the, you know, sort of old school fee-for-service? So I just want to put that out there, as that's what I'm really going to need, that pressure kicking the tires, pressure testing, understanding, you know, a range of assumptions around what we think we're generating from federal dollars into the state under various scenarios. I'm happy to just leave that there and ask some questions then after that, but if somebody wants to have comments about what that testing looks like, pressure testing looks like, I'm happy to hear that too.
I'll just say that we're taking notes, and you know, we'll definitely, I think the areas you raise are interests of all of ours. So yeah.
Great. Okay, perfect. Thank you. I just think it's important as we start to think about this. I just also wanted to ask a couple of broad questions about the term sheet. So there's the statewide accountability targets. It sounds like the all-payer TCOC and the all-payer primary care investment amount and the quality targets are yet to be determined. I'm just wondering, what is the timeline on determining those?
Boy, I'll have to dig into my memory there because I haven't thought about this stuff for a little while. Let me just say that with the quality measures for the statewide accountability, states have been asked to select at least 6 measures. They're pretty, you know, the measures are prescribed to some degree, to a large degree, by CMS, and of course we can augment, but they're, you know, so the measures themselves are laid out. The targets are either going to land in they're not going to land in the agreement because we won't have time. I think we lay those out in the statewide health equity plan, if I'm not mistaken. And that is a first year activity for the model. And you know, similarly, the all payer total cost of care, we have to have a process outlined, either an executive order, regulation, or statute. And so we'll be laying out the process and then developing the targets subsequent to that. And we can get, forgive me, it's just not right.
No,
at the front of my
I know you've
brain.
got a lot on your
And
plate.
if
Yeah.
others want to jump in, they should feel free. But
I know, and
we
Pat, I
can-
feel bad. You've moved out of this role and here you are pinch hitting for others. So it's most appreciated that you're here, and your memory, do not worry. I understand you're pinch hitting today. So that's also appreciated.
Thank you, but we can get those dates to you.
Well, I guess it's part of a larger question I think I have, which is that we're trying to hasten the signing of this agreement. We have accountability targets that haven't been determined yet. We have investment and access targets that don't even come into the model until performance year 4, which strikes me as really late. I think even the equity and state transformation plans, which I wanted to ask about too, the timing on those, who's deciding those, with whose input, what's the timeline for submission? I mean, I feel as though understanding what the goalposts are at the beginning of the model seems really important. And also, it seems as though, these investment and access targets, the equity plan, the transformation plan, these seem like critical components of the roadmap for care transformation that is supposed to be happening simultaneous to this. Establishment of global budgets, East Fund allocations. Those East Fund allocations, presumably, if we earn dollars and have that Delta TCOC in the first year, we're going to be allocating funds, but we don't, at that point, may or may not have a transformation plan, may not have, investment and access targets. So I guess maybe I'll just ask more broadly, how is this all going to work together? How are we establishing the goalposts early enough in the model so that the investments that we're making, potentially allocating, and the global budget designs that we're implementing are all part of a bigger picture of where we're trying to move the state in terms of equity and access and quality and cost and affordability and all that?
Yeah, thank you. So Fran Hodgins helped me out. Thank you, Fran. And put in the chat that that we're, what we think is happening is that no later than July 1st of 25, that we would document statewide quality and equity targets in a separate document. So that's the deadline that CMS and that we are looking at. If, assuming cohort 1 participation, we'd be looking at July 1 of 25 for those targets. In terms of how everything works together, and again, I invite others to jump in if it's okay with the chair, others who have been on the negotiating team and such, it clearly, the goal is to have, there are the ahead goals, sort of the broad federal goals in the model. There are, the Medicare specific targets. There are the all payer targets, and that includes primary care investment, quality and equity. In, what CMS is talking about with Vermont, there are these investment and access targets, which I know has been something very important to the board. That's a little ways down the road. And as we mentioned earlier, there's nothing that precludes us from, rolling up our sleeves and getting to work on those sooner. So clearly, the idea is that all of these components work together, that they align, that Medicare aligns with what Medicaid is doing. And in our case, like for primary care, that's the Blueprint for Health, and it's multi-payer. The idea is to drive toward those overarching goals of reducing growth and costs, of increasing investment in primary care, of reducing disparities of health, addressing health equity, and improving quality. And the state has some latitude on, how to, which measures to focus on, whether to augment that with additional measures. And and, for the all payer work, the target setting, so there is a certain overarching feature of this model that really looks at everything aligning with those goals. That might be easier said than done, but everything does appear to have a way of tying together. So
maybe for expediency and knowing other people want to speak to, maybe it might be helpful to add to the timeline when the accountability targets will be set. As you said, July 1st for the investment and access targets, even though I guess it's not submitted until performance year 4. It sounds like July 1st, perhaps we'll have them. When is the state equity plan going to be submitted? When is the state transformation plan? That would just be really helpful for me to understand when are we going to have all the pieces together so we have the roadmap of where we're going. It'll help me understand if this is feasible, and seamless integration of all the parts in advance of actually trying to implement it. I will say I'm not going to go too much into this, but I share some of the concerns that Dave raised about out-of-state spending. And my concern is exactly the same. So I'm just going to say, could we be creating access barriers for patients if there's some incentive for capping in-state hospital revenue and then held harmless for increases of out-of-state care? Hospitals that have affiliations with out-of-state hospitals could actually move that care out of state, right? A UVM could shift Vermonters to New York hospitals. It would keep their global cap low, and it would help us be, not trigger those total cost of care targets. But is that great for the patients in Vermont that may be forced or encouraged to seek care at, either higher cost or lower quality care farther from home? So I just don't know how that works, and I think we should think a little bit harder about that piece. I did want to ask if there could be some analysis about the EPC payments, and Dave brought some of this up. So we know that it's $17 on average. It's only paid out for traditional beneficiaries, right? So MA beneficiaries there would be no dollars for those. So I think it would be helpful for us to really understand what are those EPCP dollars coming into the state by year under various assumptions, right? So what are the proportion of practices that would be eligible in each year? For example, pediatric practices that are primary care pediatric practices, I'm assuming are never eligible. They don't treat Medicare beneficiaries largely. Hospital-owned, eligible, depending upon, I guess the rural health clinics would be, but if they're not hospital-owned, they're not. So really trying to figure out how many primary care practices are actually going to be eligible in each year for these payments. And then also considering that Medicare Advantage penetration and, kick testing the tires around that. If Medicare Advantage penetration grows under those scenarios, how much money are we really talking about coming into these primary care practices? How many practices are going to benefit? I think we just need to model some of that. I also wanted to ask in the term sheet, what is the inflation rate that's going to be used to increase the EPCP? It just says inflation, adjusted for inflation. Do we want to put something more specific on that?
So I'll try to, there were a couple questions in there. Yeah. The EPCP, we can, because we know for year one that it's $17 average PM, we can, model out if X percent of Medicare beneficiaries, fee-for-service there's about 108,000 Medicare fee-for-service beneficiaries in the state currently. The whole MA penetration thing, others I think have thought more about this than I have, and I can't quite get my head around it because, we have had growth in Medicare Advantage penetration. The growth, my understanding is it's slowed a bit recently, but it's definitely, we've seen some growth. We have an aging population, so we have more people coming into Medicare, eligibility. I'm frighteningly close to that. In fact, I'm actually proud. I guess I'm there. And
Congratulations.
you know, and so so it's kind of hard to figure out. Yeah, more people might go into Medicare Advantage, but we've got this bolus of aging Vermonters coming down the pike. So can't really. But with the EPCP, we can model it by 50 I think we did some calculations that if 50% of Medicare fee for service beneficiaries were with a participating, were with practices that were participating, it would be, like $11 million in the first year. I can't answer what they're going to use for inflation. They tend to, look at metrics that they already have. And maybe others have heard them float a particular metric for the inflation for the enhanced primary care payments, but if they have floated it, I don't recall. You asked about the practices. Again, the bulk of Vermont's practices serving Medicare fee-for-service beneficiaries participate in the blueprint. The practices that don't tend to be your smaller practices, but it's it's the bulk of the practices in the state. So any of them are technically eligible. Those that are non-rural health clinics and owned by hospitals that don't participate are not going to be eligible. So, it's a bit, we can model it according to different scenarios. I think it's likely, several $1 million a year of the EPCP payments.
Okay. It's just helpful to understand how much money is really, it's going to what's the benefit side of this, right? How much money is actually coming into the state,
Yeah.
and what's the confidence interval around that, the high and the low of that. So I'm trying to
like you
figure
said,
that out.
ranges too.
Yeah, ranges,
thinking about in
exactly.
terms of ranges.
Just trying to figure out the ranges. Let me just scroll. I'm going to try and skip any of the smaller questions. One of the bigger questions I have regarding it's the participation of hospitals, and I think it relates a bit to the, AHEAD has been recognized as a potential way to stabilize hospitals, and would work in conjunction with Act 167 and the care transformation, and the East Fund might be helpful. And there's been conversation around post 167 Oliver Wyman care transformation as well. AHEAD is going to be one of the helpful tools here. And I just want to ask a little bit about, given that it looks like maybe it would take until year 5 for critical access hospitals really to be expected to be in, and only one might actually come in at that point. And, we've got hospitals on the brink now, right, that are struggling, and they tend to be critical access hospitals. So I am trying to figure out how AHEAD would work with ensuring hospital stabilization of those critical access hospitals that are probably at most risk, given the timeline that we're seeing for potential entry, if at all, of critical access hospitals.
Yeah, so I'll reiterate those hospital participation percentages: 10% for year 1, 50% year 2, 80% years 3 and 4. So performance year 5, if all your PPS hospitals were in performance years 3 and 4, based on, the estimates we have now of the percentage of the state's total, net patient revenue for Medicare fee-for-services, you're talking year 5, where to hit the 85%, we would likely need a critical access hospital or 2 at that point. So it does give some runway. I mean, there might be critical access hospitals who find this interesting enough that they want to join sooner. It's hard to say, but you know, if we were able to get all the PPS hospitals in, it likely wouldn't be required until year 5.
Okay, so I
I
guess
just-
from
I
what
also-
you're saying then is that we should not rely on a head to help us move care transformation
We are-
forward
I
among
don't think-
critical access hospitals.
Yeah, I don't think we are relying on a head. I think it is a component in that the East funds, even before CAUSE participate in year 4 or 5, or earlier if they so choose, potential East funds could go to those hospitals, even if they're not participating in the model
Oh,
yet.
yeah.
So I think that's
Yeah.
another component of how this fits in with hospital care transformation in the post Oliver Wyman world. And Robin, I see you were, I think you were going to chime in too.
Yeah, I was just going to say the participation requirements are minimums, not maximums. So I think that there was concern expressed about the state and the board's ability to ramp up the global budget methodology. So I think there are two sides to this. If the state can ramp up implementation of methodologies sooner, then obviously hospitals can come in sooner. There's nothing in the AHEAD model or in the federal agreement that prohibits critical access hospitals from coming in year 1. So I think the goal with the participation requirements is to give the state flexibility to do and plan for an implementation that makes sense to us without the federal government weighing in on that. So the incentive in the federal agreement is to have minimums that push out and give us runway that we may or may not want. That doesn't mean we have to take that runway. It just allows us to have the runway. So I think it's up to the state to decide how quickly it wants to ramp up. And it's in our interest to have the federal agreement give us the maximum amount of time, understanding that we may or may not want to implement on that timetable.
Got it. Okay. That it would be helpful then in some ways to have that state transformation plan, I guess, right? Because then you could apply the different state levers to encourage potential participation by those critical access hospitals and those hospitals that are at highest risk earlier, if this model would be helpful in stabilizing them, right? If we had that transformation plan, we knew which direction we were going. I don't know.
Yeah.
Trying to figure out how this all works together.
Yeah.
Let me ask, hopefully there's really three quick questions. The hospital global budget operations incentive says that hospitals that exit prior to performance year 6 have to repay CMS. What if the state decides to exit the model? Will those hospitals be required to repay that money or any other investments if the state is the one that makes the decision to exit the model before performance year
That's
6?
a question that's come up in recent days, and we want to definitely nail that down. But it would seem like if it's not, and the same, I think the corollary to that is if CMS decides for some reason to terminate the model. I think what we would want to ensure that if it's not the choice of the hospital, that they would not be required to pay back. But that's come up in recent days as well. So thank you for raising it.
Great.
Again.
Okay. Perfect. No, I just want to make sure that, that'd be a good answer to have. The termination clause, it says the state, has that been worked out? Do we need all 3 signatories to agree to terminate? Can one signatory effectively terminate without approval from the other 2 out of 3? What does the state actually mean in that?
The state is not a defined term in the state agreement, so I think that's a state level question. So I think the 3 signatories need to come to an agreement on that.
Okay. And then my last question is, and I think I've taken up too much time, but is in the last agreement, we had an exogenous factors clause, and we actually deployed it during COVID to our benefit. Is there an exogenous factors clause for this model? Should there be? I guess.
We are
think so.
expecting
we-
one.
Yeah,
Yes.
I think we could expect that there would be one for sure.
Okay. Okay. Great. And I just wondered, let me just throw this out there. It sounds like there's a lot of things that need to be resolved between this, AHS, between the signatories. It might be helpful to have an MOU around some of these decision points so that everybody's on the same page around timing of certain decisions, terminations, all of that stuff. It just seems like this is an agreement with the federal government. There might need to be an MOU between the signatories about some of the other, how the East Fund is going to be decided by whom, all of that. I just feel like that might land well in an MOU prior to signing the state agreement. So we're all on the same page if there is a decision to move forward. Okay. That's all I got. Thank you, Chair Foster. And thank you, Pat, and others who have chimed in to answer some of my questions. I really appreciate it.
Thank you.
Thanks, Pat, and thanks for the excellent questions, Dave and Jessica. I have just a couple questions, comments that haven't been covered already. I think one of the biggest things facing Vermonters with our crisis in healthcare, along with access and some emerging evidence of declining quality, but it's affordability. What commercial payers are paying, our prices have risen some of the fastest in the country, and in turn, those have driven premiums to rise the fastest in the country. And it's not clear to me how specifically AHEAD will help us address that. So I'd like more information about that. I share the concerns that Jess and David brought up about our capacity to measure and monitor performance over time. That by the time we realized the last all-payer model wasn't playing out the way that we had hoped, it was too late. And then we learned that if we withdrew from that funding for programs that do have evidence, Blueprint and SASH would be lost. That remains the case with this new agreement, that if aspects of the agreement do not make the improvements that we are hoping for, the funding for SASH and Blueprint remain tied up in it. Similarly, there was an election a few months ago, and the winner of the election is very much against equity programs. AHEAD has equity in it. I feel that puts it at risk for being deployed the way that we're discussing. And if it's not deployed the way that we're discussing, I don't know how we would fund Blueprint and SASH. There's no modeling of how that might unfold, and that worries me. This is AHEAD's very complicated. Each time I hear one of these public presentations, I wish that we had more time with public presentation and more opportunity to think together about this. Because when I look through the slides that came this morning and listen, I see that it sounds great. It sounds almost too good to be true that the East Fund could amount to $138.9 million extra coming into the state. And that could be true even if we only have 10% participation. And that could be true even if we only save Medicare 0.1%. So it seems to me the requirements for getting that transformation money are incredibly low, and the amount, 138.9 million, seems high, almost too good to be true. I feel like I'm missing something. And I feel like one of the things that I'm missing, and I've asked about, is what will it cost to administer this? It wasn't until there was only 1 year left in the last all-payer model when we had an estimate of what it cost the state after all was said and done. And while the model appeared to save Medicare a little bit, it cost Vermont $100 million. While access got worse, quality declined, and commercial prices went through the roof. We don't know what this model will cost us. So I feel like we're lured in by the blinking light of 138 million, while we only would need to save 0.1% and have 10% participation. That deal does not seem real to me. I wish that it did. But at a fundamental level, over a year of these presentations, I can't convince myself, based on what I'm hearing, to think that this will play out the way that we're talking about. And I want to. I don't like being Mr. Negative. We have no estimation of the cost of doing this. It's huge, it's complex. The amount of money, 138.9 million coming in, seems like a lot. It's not compared to nearly $1 trillion industry in our state. So, and the requirements for earning it, it just doesn't add up to me. And so I'd like more information in order to be assured that this will be a good deal for Vermonters and that it will actually be able to address access, primary care, mental health and substance use disorder, things that we absolutely need. But we also need to be able to address the high prices and skyrocketing premiums. And I'm not sure that this can do that. And it may come at a very, very high cost that we've not calculated. So, thanks for your time. Thanks for coming today, Pat. It's always good to see you. I appreciate the effort that you're putting into this. I wish I was more optimistic.
Sure. Thank you. Thank you, Member Walsh.
Thank you, Pat.
Chair Foster, would you like me to briefly respond to that, or?
Why don't we keep moving, Pat, just because I'm sure we'll have another chance to. I just want to be mindful of the time and take public comment, and so we only have 13 minutes. I will not add some questions that were similar. The one question I did have was, I know we've reserved time on the board's calendar for potential review of the the state agreement and noticing a potential vote. I just want to acknowledge these timelines have all shifted rather dramatically, and that has made this more dynamic and difficult and challenging for everybody. But the actual deadline to vote on this can you remind me when that would be? I know we have a goal of January, but what's the actual requirement by which we must vote or sign a state agreement?
Do you mean the actual requirement originally in the AHEAD model?
Yes.
Okay, so for one states, the deadline for having an executed agreement, but obviously votes would have to happen well before then, would be July 1st of 25. And if I may, I just want to clarify one thing that board member Walsh spoke to. I apologize, but I really, I do want to mention it. So the $138.9 million is an estimate. I just want to be really clear about that. You know, again, as with some of the other metrics here, the calculations are variable. that is for the first year. And it would be trended forward throughout the year of the model. So I just want to be really clear that it's more than that over the life of the model. But I also want to be clear that while the 10% participation requirement is in year one, it gets more rigorous after that. 50% year two, 80% years 3 and 4, 85% year 5. So there, and I guess the only other thing I want to say is that I know we are looking at what, in terms of cost of administration, what the model requires of the state. We've done an analysis of what we know at this point. And then I know the Green Mountain Care Board also is doing it, but we've done it, like across the whole state. So that's just a really important point that I think Board Member Walsh brought up. Thank you. Thank you for letting me digress a little. But July 1st was the term, the timeline for an executed agreement. There is definitely been a change in interest in getting it done sooner since then.
Right, and we had considered moving it up to January in light of other changes that are kind of going on in the macro environment, but the actual deadline remains July 1st. I'm going to go to public comment I'll turn to the healthcare advocate first.
Good afternoon. I don't get to say good morning anymore. Good afternoon. Thank you for this conversation. I feel like this is one of the first really honest public conversations about all of the moving pieces here and all the complexity. And I appreciate it. I think a lot of the questions and points that have been raised already are questions that we have. And so I was going to ask a question or two, but I think instead I'll just make a comment or two. I think, this discussion of the Delta TCOC or East Fund monies, I just know that there are various sectors around the state who think that is their bailout. And whether it's hospitals or whether it's other community providers that we're all worried about, or whether it's investments in new services that we know we need to build. And so I think that is a place where there needs to be an honest conversation, because this thing's not going to work if everyone thinks, hey, $138 million a year or more, to Pat's point, if that is real and not subsumed by growth in the cost of providing care, if it's real, where's that money going to go? And is it, I just know that when I talk to various people, they think, oh, here is our answer. And it can't be everyone's answer. It might sound like a lot, but it's not enough. And then the other point I was wanting to make is, thank you, Member Walsh, you sort of spoke to this about SASH and Blueprint. Actually, let me say this. Pat, the way you talked about the transfer of the monies for SASH and Blueprint, a little bit sort of more matter-of-factly, that it would go to a hospital and then the board would, through its hospital budget authority, would assure that it went to the right parties. Why? When I hear discussions about the East monies and the complexity of getting those monies to the right place, why wouldn't it be as simple as you described for the SASH Blueprint monies?
Well, I think it is. I mean, I think CMS needs a mechanism to flow the funds. We have it in our current model. The funds flow for SASH and Blueprint flow to the ACO. And so, I think that's how it still works. But, at least the community health team fundings flow to the ACO. But at any rate, they need a mechanism. And so, the hospital global budgets are that mechanism. So I think part of it is how do the funds flow? And then part of it is who has the authority to make sure the funds get where they need to get. And through the hospital budget process, that's the Green Mountain Care Board. And then the further question is, how do we decide, how these funds should be allocated? Those are all really salient questions. It's not, it's not simple for sure, but it's the mechanism that has been identified as how those dollars would flow, who has the authority, and then we will want to agree on particularly the East Fund, which is less clear than Blueprint and SASH, and potentially more funding. How can we make sure that there's a really good process for both, as Member Holmes talked about earlier, aligning that with all of the overarching and really important goals that we're trying to achieve, and just making sure that the funding gets where it can best serve Vermonters.
Thank you. I was thinking I just wanted to make this more as a statement than a question. I agree with what Member Walsh was saying a moment ago about sort of the linking of these major healthcare reform efforts to the funding of SASH and Blueprint. That's really unfortunate. I mean, there's a few things that we're doing that we really know work. And if we decide to do ahead, it's not because of funding for SASH and Blueprint. Yeah, it's linked. But the reason to do ahead is not $10 million. It's significantly more than that. If we come down on the side of that, we should do it. And so I just thought I would just say here, we should de-link. We should find an alternative way, identify, recognize it as a priority to fund SASH and Blueprint. And for that matter, we should double, triple, quadruple the amount of money we put towards SASH. I think it works, and I think we know it works. And we don't need a federal model to do it. We just need the commitment to spend the money on it. Thank you, Mr. Chair.
Thank you. I wholeheartedly agree with that latter sentiment, for what it's worth. That was one of the concerns of the last model, was the linkage. And if this model doesn't work, are you going to have to bail out of it and then have it harm independent providers or primary care providers or Blueprint and SASH? So that is a consideration in how this is all structured. I'll open up to public comment via raise the hand. David Schneider.
Hello there, David Schneider, long-term pediatrician from Rutland, Vermont. Recently stopped clinical care and focusing on advocacy. And I would like to thank very much the Green Mountain Care Board for the skepticism, frankly, that you're approaching with in looking at the AHEAD model. I certainly do have concerns. I'd say, first of all, there's an adage for prudence in medicine, as Dr. Merman knows. It's never be the first to join, nor the last to give up. And, first time today hearing that, wow, there's an opportunity for being a part of cohort 2 does give us a little bit of breathing room, I think. So I would hope at the least that you consider deferring to cohort 2, take that option seriously. As a primary care physician, I am worried about this. Now, again, from pediatric point of view, you can argue that this could actually be neutral, but I almost see it being harmful. Again, to the point of linking the blueprint to this, pediatricians are dependent upon member dollars from Blueprint right now. And again, the services, the care management services, et cetera, I don't know how this would affect pediatrics, and I would be concerned about that. So when we talk about primary care, as Member Holmes pointed out, we're just talking about a very specific piece of Medicare. We're not talking about the rest of Vermont population, and I appreciate that, and I do worry about the whole picture of Vermont, and understand that this AHEAD model is only a small piece of it, and I am quite concerned about what I am hearing overall. That is just layers and layers and layers of card shuffling, frankly. And thank you for the time.
Thank you, Doctor, very much. We appreciate your comments, and thanks for participating today and listening. Any other public comment? Great. Well, thank you, everyone, for the presentation and for the thoughts as we continue to work on this. And it is a tight timeline, and everyone's working very, very hard. And I want to acknowledge it is an immense load for everybody, given the time pressures. And I appreciate everyone working so hard. It's 12:30. Thanks for staying late, everybody. And I will move to adjourn.
Second.
All in favor, say aye.
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 Aye. We're adjourned. Thank you very much, and I hope everyone has a nice day.
Thank you.